Good afternoon. I'm Gil Rosen, CEO of Convergent. Our mission is to democratize a safer, more precise radiation therapy, the kind of radiation therapy that, as of today, is only available to patients who are lucky enough to be near a proton beam center, and that means that the kind of radiation therapy that only 0.5% of the cancer population actually gets. We do that by offering patients a focused low-energy beam that we deliver through a low-energy source, and that also means that we can do that outside of a radiation bunker. We have raised $25 million to date, and we have a massive IP portfolio of 11 patent families. We have an agreed with the FDA regulatory 510K pathway, and since 2016, we have been partnered with MD Anderson, the leading cancer center in the US. So radiation therapy is one of the three pillars of the cancer treatment. Surgical oncology is, of course, one. Medical oncology, drugs, is the second one. And radiation therapy, which is the kind of treatment that over 50% of cancer patients receive, is the third one. It's a well-tested modality in many cancer fields. Over 90% of patients are responsive to radiation therapy. The problem with radiation therapy is that it is a bit transactional. You want to kill the tumor, but you don't want to hurt the nearby organs at risk. What you see here, you see a 2-centimeter lung lesion that is fully irradiated with 56 gray, but you also see the heart, that 9% of the heart receives 10 gray. Why is that a problem? The problem is that these days, thankfully, screening programs enable earlier detection of cancer, and that means that patients live longer following treatments, and that means that 10, 15 years following treatment, which is the time frame that takes for secondary cancer to pop sometimes if there is toxicity after the radiation therapy to nearby organs, now more and more patients have to deal with that. This is also why proton beam therapy was introduced and invented 3 decades ago. What you see here is you see the same plan with the proton beam therapy, and you can see that the heart is nicely spared. The problem is, of course, the ticket price. Between $30 and $100 million for the system and a basketball court size facility for each one of these centers. Again, this is why, to date, since the 90s, fewer than 300,000 patients actually received proton beam therapy. That's why kids from Israel and from Canada have to be flown to the US to be receiving proton beam therapy. This is where Convergent comes in. We're looking to deliver a similar dose distribution to a proton beam therapy through our revolutionary beam, and we will do that in a price point which is competitive with LINAC, in other words, a fraction of proton beam therapy. This is what our system looks like. In this case, you can see it's delivered robotically through an AI-generated treatment planning software. The beam is delivered in what is referred to in the industry as pencil beam scan mode. In other words, we populate the target, the tumor, with dozens of small fields that fill the tumor with just the right amount of energy. But since the beam itself is actually hollow, the tissue before the target and the tissue after the targets are non-impact. This is at the heart of our system is this lens that, much like we all did as kids with a magnifying glass for daylight, our lens can focus the X-rays, the low-energy X-rays, to a narrow spot, 1 to 5 millimeter wide, using a low-energy source. That means that all of this can happen outside of the radiation bunker or the cancer center. We're going to be going for metastasis in liver, brain, bone, and lung, head and neck lesions, ocular lesions, pediatric lesions, and of course prostate and breast down the road. In addition to this proton beam-like dose distribution that we are very proud of, we also have 3 different additional innovation that are currently held back by the limitation of high-energy LINACs. And these are the SFRT, the ability to actually preserve the tumor microenvironment, which has a synergetic effect with radiation if you don't actually kill it. The ability to radiosynthesize nanoparticles. Nanoparticles are used when a tumor is radiation resistant. However, only low energy can actually excite these nanoparticles sufficiently. And another area, which is an area that is currently undergoing research in MD Anderson with us, is the higher synergy between our radiation and immunotherapies, very important areas. These are our clinical partners. In addition to MD Anderson, we're working with Brigham and Women. This is our go-to-market plan. We are looking to be FDA approved by late 26, early 27. We have, as I said, an agreement with the FDA on the pathway. We already have 4 LOIs totaling $10.5 million, representing 4 orders of these systems. 2 of them are from proton beam centers that understand what our beam can actually do. We're looking to offer lower cost offer to developing markets. And on top of that, we actually have a secondary product line in the market, which is our incisionless innovation of chronic pain and refractory epilepsy. That adds another $80 billion to our otherwise $9 billion addressable markets. The second pipeline product is refractory epilepsy. Today, 1 million epilepsy patients don't respond to the initial line of treatment. And again, we can offer these guys the ability to pinpoint just the right area in the brain to be ablated, what is otherwise done today by drilling. We are raising $30 million on top of the 25 that we've raised to date. We're looking to use the money to bring the product to FDA approval, and we are projecting to reach break-even on sale of 18 units. The first 4 already ordered, and we're happy to follow up with anybody in the crowd who wants to hear more. Thank you.